Hello, everyone. Dr. Nick Verma here with another edition of Things I Didn't Learn in Med School. Today, I want to talk about a big disservice that our medical industrial complex is doing for our patients. I got a direct message on Instagram a few days ago from one of my friends who said, "Hey, my back's been bothering me for a while. I went to my primary care physician. My primary care physician prescribed me some Advil, prescription strength, took some x-rays, and gave me some exercises to do at home. Didn't get better, and then they sent me for an MRI, and now I have an appointment with the surgeon next week." There are problems in every step of this pathway that I'm going to kind of lay out for us right now. And this example is just for back pain, but I hear it all the time for things like knee pain, shoulder pain, hips, ankles, what have you, any musculoskeletal injury, um, even nervous system, carpal tunnel syndrome, um, or other neuropathy syndromes. The primary care physicians, well, they don't have a strong grasp. Well, I'll take it back. Not all of them have a strong grasp on the neuromusculoskeletal system. So when they see a patient, they go based off of what's taught in their residencies or maybe in their fellowships of, hey, we treat them with the base of non-steroidal anti-inflammatory medications, Advil, naproxen, what have you, um, maybe some Tylenol. Um, in rare cases, it's becoming more rare, but there are plenty of cases that these primary care doctors will start patients on opioids, tramadol, or other stronger medications that may not be necessary. In the area of neuropathic pain, neuropathy, or sciatica, they'll prescribe gabapentin. And this is doing a disservice to the patients in many ways. First off, we know that non-steroidal anti-inflammatory medications are not innocuous. They have lots of side effects. We know that it can decrease your kidney function and cause kidney damage. We know that it can cause gastrointestinal bleedings. The other things that we are starting to learn more and more is it can increase your risk of heart attacks and strokes and other peripheral vascular disorders. We know that long-term use of non-steroidal anti-inflammatories can actually inhibit your own body's mechanism to produce positive inflammatory markers that can help with healing. Um, we know this is well studied in the literature of orthopedics is we don't recommend non-steroidal anti-inflammatories after surgeries because we want that good inflammation there to help you heal. So there's one of the problems of poor understanding. Now, there's been studies out that show the increased risk of heart attacks and strokes from these non-steroidal anti-inflammatories uses, and they've increased the warnings out there. But a lot of these primary care physicians still reach that as their first line of treatment. When first line of treatment, as we know, is should be a solid physical therapy plan combined with diet recommendations, anti-inflammatory diet, eliminating processed food. I think a study just came out showing that 60% of the US American calories are coming from ultra processed food, which is an insane number. And that is directly contributing to what we call neuroinflammation. And that also leads to inflammation in our bodies, which in turn can lead to more pain. Um, and so going back to the primary treatment options for someone that's dealing with different types of pain is physical therapy regimen, diet and exercise, exercise including cardiovascular exercise, as well as resistance exercise. We know that people that have stronger muscle mass, bigger muscle mass, have decreased joint pain. Now, we're not talking you have to go be Olympic world lifter. We're talking increasing your muscle mass by 1 to 2%. And then when you get above the age of 35, 40, it gets very difficult to increase your muscle mass, but you can maintain your muscle mass by lifting heavy weights. Relatively heavy for you may be different from someone else, but it's very, very important. And then the other big concept of primary pain prevention is a good, solid sleep regimen. Have good sleep hygiene. Get 8 hours of sleep. Stay well hydrated and get 8 hours of sleep. Stay well hydrated. Excuse me. Stay well hydrated during the day, so you can not be dehydrated at night. Make sure you have a good dinner, so you're not having spikes of insulin and glucose throughout the night. Um, these are all very, very important things for pain reduction. Now, say all these things don't work. Some other things that we can add on are things like acupuncture, massage therapy. Even there's great chiropractors out there that can help move pain and help alleviate symptoms. Um, Topical rubs can have a lot of benefit. I like rubs that have magnesium in them because those can help significantly with muscle aches and pain. Others help with some inflammation. Now, again, I want to come back and say that the medications that are used, they're not all evil. Don't throw the baby out with the bathwater. These things can be used and can be used responsibly and can be very effective. For example, for myself, when I hurt my ankle a few years ago, I really took my non-steroidal anti-inflammatory medications for 2 or 3 days to let the really acute pain settle down a little bit. But I focused on all these other things, and that was early range of motion exercises, getting with a physical therapist, working on my ankle range of motion, and then working on strength over the next few days, and really making sure I was getting in bed at a really good hour, and making sure I wasn't staying up all night, and allowing my body to heal. So, say all these things fail, that would be a good time to look at X-rays and maybe some mild imaging to see what's going on. Um, Quite frequently, I'll order those testing at the beginning too, just to make sure that there's no fractures. I won't fault anybody for doing something like that, especially with a severely rolled ankle, or just seeing the degree of arthritis in the knee, because that may alter how you want to treat. Meaning, if I see arthritis that is severe in one portion of the knee, I might recommend bracing while they're going through their therapy to make it more tolerable. Or I might recommend a foot wedge, very similar to something in the back. If they have something that's called spondylolisthesis that causes a slight micro motion in the spine, it might be better to do certain types of strengthening and stabilization exercises versus a different subset of flexion exercises. It's a little bit going into the weeds, and it's more of a personal philosophy, but it's kind of how I look at it. So those things might be beneficial to get at the initial visit. But this is why I think PCPs should be relying on their physical therapist colleagues, their sports medicine colleagues, and interventional colleagues, such as myself, who are trained in physical medicine rehabilitation. Um, which puts us at a second turning point in this pathway of where do patients fall for treatments? Because, as I said, we did the physical therapy. So we get the x-ray imaging, they do home exercises without guidance, real guidance, and then they get an MRI, and then they don't get better, and then they get sent straight to a surgeon. Well, there are other options, and that's where interventionalists that are trained in physical medicine rehabilitation really come into play. I had a conversation with my girlfriend just last night, and she was talking about one of her patients who was sent to a pain management doctor. And she was a little confused. She's like, "Yeah, this pain management doctor does a lot of injections too." And I told her, "There's a lot of pain management doctors out there, not all, but their company is based off of having a subset of patients that are on opioids because that is their returning revenue month after month after month. Now, the other subset of patients and where they make a lot of profit is through procedures. And now, don't get me misconstrued. Don't take this as a soundbite, whatever. I'm just trying to explain a concept of that is their subset of patients of how a pain management clinic works. In hospitals And now private equity, see how profitable this is like, hey, let's chalk or block our clinic full of opioid patients, even if it's a low dose, and just make sure that we have that month after month recurring revenue, and make our profits, our bigger profits, by doing high-end procedures. That's kind of how the model's set up. If you don't like that as a pain medicine doctor and you're watching this, I'm sorry, that's the reality. I know it, you know it. That doesn't mean you don't want to get your patients better. I truly believe that most the pain medicine doctors I do know out there are actually trying to do best for their patients, but that is the model. But that's where people will, especially primary care doctors, will sidestep sending patients to a physical medicine and physical medicine and rehabilitation trained physician, because they say, what's the point? I don't want them on pain medications, or maybe they don't need pain medications. I just want to see what the surgeon says. I don't know. This is the conversation that I had a lot of problems with. I still do when I go to my primary care colleagues in the central Ohio area. They were like, oh, so you do pain medicine? I'm like, not really. I really work on the functional steps, and I address these nutritional needs, these sleep needs, these hydration needs, and I do the assessment of where they might be falling short physically, and what we can do to get them better. And I have a lot of physical therapists that I work with that I can communicate these terminologies with. But these primary care doctors will not send to me because they just view me as a pain medicine doctor. And when I was explaining to my girlfriend, it's like, yeah, that's part of my reason I don't prescribe opioid medications, because I feel like I'm in a different subset. I'm treating a functional problems. I'm not really treating just pain. Now, with the nature of what I do, pain comes as a conversation I have with a lot of my patients. And chronic pain, I have a lot of patients that have chronic pain, and we try to deal with it with some of those tools that we discussed in combination with physical therapy, chiropractic, acupuncture, cognitive behavioral therapy, and what have you. So, going back to this algorithm stepwise of how our current medical system is disservicing our patients, is going to the primary care doctor, getting this imaging, going to the surgeon. Now, the surgeon's either going to say one of three things: is one, okay, there's a surgical lesion, let's sign you up for surgery. Two, hey, this isn't surgical yet, or I don't think there's surgery here, go back to physical therapy. Or three, somewhere combination of those, and maybe, hey, let's try an injection to see if that helps. Now, I'm going to have a lot more videos in the next few months talking about how I don't believe steroids should be the mainstay of injections for patients, and why we should start relying more and more on things like PRP and platelet-rich plasma and mesenchymal stem cell procedures such as lipofat and bone marrow aspirate, or just bone marrow injections. But that's a conversation for another day. But this is unfortunately where we're at. And then this patient who is probably in pain now only has three options: going to physical therapy, which may or may not help, and quite frequently, and I've seen this firsthand, not going to say where, patients will go to these physical therapy places that are tied to the hospital or tied to the orthopedic center, and they have the physical therapists have no incentive to get their patients better. Actually, they're making more money if that patient goes to surgery. Now, I believe that individual therapists probably do care a lot about their patients, but when the organization fills your schedule up with more patients than you can see, then what these physical therapists do is say, hey, go walk on that treadmill for 20 minutes. I'm going to do 2-3 minutes of physical work with you, and then I'm going to give you home exercises, and then I'm going to bill for the visit. Everybody makes money, and now I, as a physical therapist, is not so overwhelmed. This is why I work more with one-on-one physical therapists or smaller group practices that actually care about getting their patients better. So this is again another disservice to our patients, why they're not getting better. And again, these organizations, money is in the surgeries. They want the surgeries to happen, despite the outcomes. And sometimes surgery works great. I do think surgery works great for several things, but I don't think it's the end all be all. And quite frequently, patients will think, let me just have surgery, I'll be out of pain. And then they come back to me and say, hey, I'm not out of pain, I had surgery. What happened here? Said, unfortunately, surgery doesn't fix pain. It usually fixes a functional problem. Um, and that's a big conversation I have to have with a lot of my patients. And hence why I am more interested in things like the orthobiologics, aka regenerative medicine, if you will, platelet-rich plasma and the mesenchymal cells. Um, but yeah, so that's another disservice that we have as the continuum of care and neuromusculoskeletal health of the U.S. Landscape. And I think that we should do better. We need to do better. I would encourage you, if you're dealing with a neuromusculoskeletal injury or dysfunction, try looking up your physical medicine rehabilitation physicians in the area, whether they be interventionalists like myself or trained in other sports medicine fields, or even if they're just general physiatrists, physical medicine rehabilitation physicians. I think you will get a lot out of just having a consult with them before or after you consult with your surgeon. Um, I think more and more places are seeing this, and places like hospitals for special surgery in New York, they're really starting to encourage their patients to have an establishment with physical medicine rehabilitation physicians. Orthopedic centers, big orthopedic centers in the area in Columbus, they're starting to hire non-surgical physiatrists to take a look at their patients and do some of these things on top of doing things like nerve exams, EMGs, nerve conduction studies, and what have you, and being on the non-operative, non-interventional side. So anyway, I think this is a major point of where I find some contention with the current medical system, um, a disservice we're doing to the patients, something that I want to put out there and educate people as, like, hey, we have the tools out there to help you out. I think it's worth your time to do some ownership into your own health and take some onus and work with someone that actually cares about getting you better and not just feeding the system to make more money. So, anyways, I hope you guys found this useful. If you have any questions, comments, please drop them below. Send me a message, send me a DM. And if you want to work with me, my website is in the link below, and feel free to reach out and we'll work with you. All right. Take care. Bye.